The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome once again to the Pediatric Lounge. This is your host, Dr. Herb Bravo, and with us is Dr. George Rogu, host of the Pediatric Lounge. We have the pleasure of welcoming Mr. Chip Hart from Physicians Computer Company in Burlington, Vermont. Chip is the chief evangelist for pediatric independent practices across the country and one of the most knowledgeable data scientists in the space of pediatric independent practice. He's a good friend of George and mine, and we're really glad to see him in the lounge as we record 2 episodes this week. One on general pediatric practice and a second one with a deep dive on data of pediatric practices. Please welcome Chip to the show. And I'll push back a little against you because you see the top performing practices in pediatrics. There's a lot of pediatric practices out there that have really poor quality. Really poor quality.
I think there are certainly some, because, I've looked under a lot of rocks. I think, I've seen some horrifying stuff. I will say this. I think one thing that physicians in general don't do well is they don't kick enough people out of the club. Mm-hmm. You guys every year ought to take the bottom performers and say you're no longer allowed to practice till you go back to school because this is this vital and important profession that once you get that degree and kind of check in, you can see, the paper, the newspapers have articles every day. Some of your peers are insane. All right.
And
you can't get rid of them. I'm
not even talking about the insane one. I'm talking about the one that's been in practice for 20 years. And I go cover their office and I go, hey, by the way, how come you're not having the kids come back at 30 months for the autism check? And I'm like, what? There's another well-child exam?
Yeah, I do consider that a form of insanity.
I'm like, you're losing money. I not only you're not doing,
it's bad care.
You're not doing the right thing. You're losing money. Well,
you're losing the engagement with that patient. You're losing an opportunity for you to have face-to-face conversation with a mom who's been told some cockamamie thing about the COVID vaccine harming their children. It gives you a chance to a big part of what you do is actually give confidence to mothers. Like that's a big part of your jobs. And that, and that, I will also say this, the most important thing you guys did during COVID is you got the United States back to work. If you can't get vaccines into those kids or if you can't be available for kids to get vaccine tested or whatever, kids don't get back into school. Kids not in school means parents aren't working.
That's right.
It's simple. You guys were one of the 3 or 4 key pieces to the United States economy working.
So I do think the government and the private payers should require data back to see how good of a job I'm doing. And they should be more aggressive. If I can't be at the 50th percentile on some of these metrics, like how many well-child visits I'm doing in the first year, charging for the screening test, then I'm out of the network. And that would...
I think I agree with you in general. What I would want, though, all the things that make me afraid are, I want pediatricians being the ones who set the measures. I don't want it to be some
government,
devil at United Healthcare figuring this out because they're basing it on their financial numbers. I want actual pediatricians who, so the devil's in the details,
right?
But as a rule, I would like to see standards.
We have no.
You know this. The way that I'm picking on United a lot. They're not even they are the worst, but they're not even the ones who started this. It was actually, I think I'm saying this wrong, but it might have been one of those Massachusetts practice or payers like Harvard Pilgrim. Like the first time I ever saw the gold, silver, bronze, like quality measures on doctors, to talk to, which were on the surface describing what you were describing, her, which is like, these are the doctors who have the best quality. No, it had nothing to do with quality. They're
Cost.
calling them gold, silver, and bronze. It had everything to do with cost.
Yep.
And that's the part I would want to eliminate. Cost in pediatrics is immaterial.
Yes, I agree with you there. We're chasing the wrong thing. The cost is so minimal that we don't really have an opportunity to cost savings. We just have an opportunity to do harm by not spending enough.
That is at 110% correct. I agree with you.
So the world is changing. Do the old KPIs like first pass rate, days in accounts receivable, and net receivable rates, are they still important to follow for a practice?
Great question. The answer is yes. All right.
Okay.
There's some, and like as over the years, I think we've refined some things. Okay. So one huge difference between the KPIs of the good old days and today is that since so many of the financial transactions are automated and electronic now, like way back when 30 years ago, it could take a billing department a week to get a claim out. All right. These days, you should be able to claim out same day or the next day. All right. Many of our clients do. So it highlights a few places, a few measures that are they're like, because one big chunk of delays was eliminated, where there are two measures that I look at a lot more now are, I'm always looking for slight changes in AR that are over 30 days. Okay, so in the good old days, your big AR days number was the big number. That's useless almost. But I want to look for little bumps at 30 days and 60 days. And I want to do it that by payer, because that will tell me if a payer's yanking my chain really quickly. That's number one. The other thing I really start looking at is, George, you know this from your old practice. When your practice ran on paper, there was just a huge amount of inefficiency and delay that was sort of built into the process. And so now, if the billing part, if literally when you're in your exam room, when either one of you is in your exam room and you see a patient 99213 and you hit send a billing and it's an automated process and that claim goes out that day, okay, and we eliminate all those steps that used to be in between. Now we're going to really, really highlight the amount of time it takes for a doctor to finish his or her notes. Okay. And there is a shocking range of, it looks like a long tail. So, I've got the data, but most of our clients have finished their notes and sent them to billing within a day and a half. All right. That's the majority of our clients, but we have some clients who are average like 6, 8, 10 days. That's average. And that means they're finishing chart notes a week or two after the visit. I'm like, that's unsustainable. And so that's a measure I look at a lot. I also, I've not eliminated at all the financial measures, because all those measures, revenue per visit and stuff like that's all still crucial. But two things are really important. Number one, COVID screwed up all the benchmarks. You can't go in and like, what's your revenue per visit right now? It doesn't really matter, because first of all, there was one part of COVID where you only did well visits. So your revenue per visit shot through the roof. And then there's another part of COVID, like in the fall of 2021, where you did 6 zillion COVID appointments that were a lot less expensive. So some of them you have to put into context. The other thing I've learned is, and I can't overstate this, it is almost impossible to divorce a clinical measure from the financial measures. That is the same discipline that makes a practice good at doing patient recall, like doing MCHATs, doing those 30-month visits. I mean, right now, think in your mind, think of the last practice you visited. They're not doing the 30-month visit. That's not the only thing they're not doing.
Oh, that's right.
It's always the case. And so what I found is, I mean, you know this as doctors, when you walk in an exam room and and you've been given a certain visit reason. Okay. You've done this a lot, and there's certain things you're looking for. Well, I'm going to ask this question and this question. And if they answer yes here, I go there. I mean, like, this is medicine. Yes. I do the same thing. So someone calls me and they're having trouble making payroll, and I ask this question, and guess what? I could talk to them for an hour about, their revenue per visit, or I could just simply talk to them about the fact that they're not doing well visits, because that solves the revenue per visit problem. So they are related. And I find more and more that the practices who provide good medicine are performing well financially. That's true 90% of the time. It's very, very rare that a high clinical quality practice isn't performing well financially. And I'll say this to all your listeners. If you're a listener out there who thinks he or she is kicking butt clinically and the money's not there, come talk to me. I'll show you. I'll either say, yeah, you're right, it does suck to be you, or I will show you where you're wrong, and maybe we can fix your practice.
I'll push back a little bit. I think
Please.
that when somebody's starting a practice and they're learning to delegate some of these processes.
Mm-hmm.
And so it's important to still have a very high level dashboard that shows them the trends and then drill down as to where they're having a gap.
Mm-hmm.
Because that's not something you learn in medical school.
No.
And so that's important to get into the mindset of, I really, as a physician, need to practice at the top of my license. My A game should be $300 to $400 an hour. If I can delegate this to someone's $25 an hour, or I'm already paying for the service, I should not have to go fix it. I should just say, this is what I need. This is what I need this number to look like. It's your problem, Chip, because I'm paying your company to do it. Can't do it. We're going to have a conversation about who can do it for me.
Yeah. The thing is, I would love to work with a lot of practices who have that mentality. Most of the time we're just doing our best to, lead the horse to water, because I'm like, hey, have you ever heard of a sick to well visit ratio? No. Well, let me explain to you how you measure it and why you get there. I mean, we have a dashboard and we use it every day. And, one of the secrets that I've learned about it is, the simpler we can make the dashboard, the more I don't want to say dumb it down, but the more detail we actually take out of it, the more impact it has, which is, for a nerd like me, that's a little contradictory, and I don't necessarily like it, but it's the truth. If I can show them one simple picture, it tells a story much better than one of my more complex storylines.
And so to continue on that, what do you think a practice should be measuring on the quality side? For example, I think rate of completion on HPV by 13 is very important, and there's national benchmarks, so you can measure yourself. The CDC has a website. I'm sorry, the AAP has a website that shows you what that rate is in your state, what that rate is nationally. And it's something that it's actionable, that you could implement strategies to improve it.
Yep. I like that one a lot. In the good old days when George was a client of ours, we actually used his practice as the demo dashboard practice, if you remember that. Yeah. Sorry, we've got America flying overhead. They might send a couple F-35s over. We'll see what happens. But one of the reasons I like the HPV measure is because it's actually a secondary measure. If you have a high HPV vaccine rate, that means you also have a good adolescent well visit rate. Okay. This is going to be a lot of fun for your editor. I can't control it. So so I look at, I'll tell you the things that I jump to right away. I jump to HPV. I jump to depression screening. What percentage of your teenagers have had a depression screen in the last year? Because that tells me, first of all, that number is not going to really be any higher than your well visit rate for those kids. And it tells me if you are doing those visits or doing those screenings during those visits. So I look for those two things. In the newborns, I look for the Bright Futures MChats, what is it, 9, 18, and 30, or whatever, the 24, whatever those dates are. I look for those. I look for, I'm dancing a little bit away from what you were bringing up. I look for the use of the 99050. and the 99, and more importantly, the 99051, which is the after hours or weekend codes. All right, that not having any isn't necessarily bad, but working on weekends and not having any is. So I look for those. I look for 25 modified 99213s. How often is this practice doing sick visits and recording them at the same time as well visits? I look at that a lot. Trying to think what else in this vein. Oh, I'll tell you a doozy. Here's the thing that I've made more money secondhand on than anything else in the last 5 years. I do a bunch of IMS admin analysis. What I do is I grab all the immunizations that a practice has given. I count up all their CPT codes. All right, it's a standard report in any system, and well, in most systems. And I put them all on there, and I do a comparison matching of vaccines to primary admin codes. All right. And just as an aside, because no one on this call has that KPI, I will give it to you right now. Your vaccine count to primary admins should not differ by more than 0.2%. That is my over under. Okay. So I look for that. I then also look for expired vaccine codes, because you would be stunned to know how many of your peers are still giving HPV-4 vaccines that haven't been available for purchase in how many years, 10 years or whatever the number is. I have no idea. But like people, what happens is they loaded the HPV code when HPV came out and they never updated it, but they're still getting paid at the old HPV rate and no one's really paying attention. So I look for that. I'm sure I'm forgetting something good. I mean, and what most of these do is, and you'll note with the MChat and the depression screening and the HPV as well, I'm effectively picking up all the well visit coverage rate ones. All right, not perfectly, but you don't give MChats as a rule, all right, at 9, 18, and 30 at sick visits. And so I look there first and foremost, because that tells me a lot about the practice. And here's the quick way to do it. If everyone here is like, oh, I can't figure that out, I'll make it really easy for you. I'm giving you guys like inside baseball right here from a consultant. The first thing I do when I look at a practice is I get a CPT dump of over the last year. I want to know how many of each of the different procedures you've performed. All right. So I'll see 2,009 6127s and 3,99213s. A really quick and dirty thing you can do is go right to the 96127s, because those are depression screens as a rule. There are exceptions to all of this, but it's a real quick and dirty thing I can do. I count up your 96127s, then I count up your 99394s, because those are your adolescent well visits. And if you have 500 96127s and you have 1,500 99394s, I can say with some security, you're not doing depression screens, or you're either not doing them at all, or you're only doing them at some well visits, which is not kosher, or you're not billing for them, or something's going on. If I see a practice that has 1,500 96127s and 1,200 99394s, then I know they're doing depression screening properly. And so that's a really, really fast way for me to tell like what's going on with the practice. Of course, there are exceptions. There's some states or payers where you're going to bill a 96110 for that, even though you shouldn't. There's sometimes, I'm trying to think of other examples. There are some other funky codes you can use, but by and large, I can look at 96127s, compare those to 99394s, and I already know it's the same thing that you guys have when a family comes in and you smell smoke.
Right.
It doesn't tell me everything, but it gives me a really good place to start.
Okay. So the all KPIs are still important.
Yep.
Just because that's the blood of the practice, right?
That's general business 101.
Right.
Yeah. Yep. Still valid.
A heart can't pump without blood.
Right.
A business can't run without cash flow.
No margin, no mission. That hasn't changed.
Yeah.
And then look at your HPV rates and your ratio of depression screening to adolescent well child exams.
That's, if you want your 30-second well check, there it is right there.
Okay, great. Those are great things to look around.
Yeah.
And then I was just going to ask you for the fun of it. How can One Medical be sold to Amazon for that multiple when each office they have generates
It's about the data. It's about the data. It doesn't make sense otherwise.
Yes.
Yeah. So they want your data. It's Amazon's in the data business. They're in distribution and data. They don't actually make anything. All right. They are in the distribution and the data business, and that data is worth $1 zillion.
Okay.
So yes, when you have someone who is who doesn't fill out an MChat because they don't want the answers in there, like I'm a little sympathetic to it because I don't want Amazon with that data either. And that's what that's about, and we should fear it a little bit. Yes. I live in a house that receives 1 to 2 Amazon cardboard boxes a week. I understand it. I've joined the army like everyone else. The convenience is insane, but ordering, what did I order this week? That's so stupid. Ordering
Food.
a bottle cleaner so we can clean out all our water bottles is different from medical advice. I think the what's the word I want? I think the commercialization of personal relationships is not going to succeed.
No.
I tell every practice, if a vendor comes in and says, I have the solution to your problem, it's called X. It's technology driven. That's when you kick them out of the office.
Yeah.
No.
They have a tool that's going to help you solve a problem, but they cannot solve your problem.
No.
And
it might just make your problem 10% easier. Like there's no, this is you are still, as pediatricians, very much in the relationship business.
Yeah. That's the one thing we can control.
Yeah. Your parents like you.
Yeah, believe it or not, we're the most popular doctors. Everybody loves the pediatrician. We're like rock stars.
No, it's the truth. And it's the thing that Amazon can't put in a box.
Mm-hmm.
So I think Herb, I'm going to agree with you completely. I think when someone comes along and is basically trying to tell you, look, this is the problem that you've had all along. And so, no, the problem I've had all along is not in my exam room. Usually it's usually these third parties who are trying to get a piece of that thing that happens in the exam room, and they want to get in between me and the patient.
Yeah.
And you got to watch the people who are talking about that, which is exactly Amazon and One Medical.
Yes. So you alluded a little bit to it, but how did COVID change the pediatric practice? And which changes do you think, like 1 or 2, that are not going to revert? We know like for the big companies, only about 40% of their employees are going back to the office. And it seems like that's going to continue to be the case.
Mm-hmm.
What changes happened in the pediatric office that's independent that COVID forced it and you think will remain?
There are a couple really obvious ones. The big one is telemedicine. All right. And you're like, yeah, but it hasn't been that big a deal. I'm just saying, no. Telemedicine is still 4 to 10% of the visits that occur in pediatrics. And if I had told you in February 2020 that overnight, because there was a period of time when the majority of sick visits that were being done in peds were telemedicine for that, during that peak COVID. If I had told you, by the way, the thing that you do every day, 5 to 10% of your visits, the modality that you use to converse with your patients is going to totally change forever, no one would have believed me, and everyone would have fought it. Right now, everyone just shrugs at it. Telemedicine, whatever. Okay, it's like, so that one happens with, telemedicine was the equivalent of a vaccine shot. Everyone cried about it until it happened, and then you're like, oh, it's done. It's not that painful. Now we've got a long way to go before we get good at telemedicine, before we understand it. We're still to be, that telemedicine is like the first polio vaccine. Okay, I realize it was oral, but whatever. And so there's that. The other thing I'll say is this. I actually gave a talk about this at PMI. I think the biggest change to pediatricians, and they're already starting to forget it, which is a shame, is that it gave everyone a glimpse of the life of a reluctant hero. how both exhausting and rewarding it is. If you are a practicing physician and haven't, first of all, felt overwhelmed in the last 2 years, I don't know how that would be. I don't know how that's possible. You're inhuman. But if you also haven't felt, had some acknowledgement of the importance and the validity of your work, if you haven't had that, I really want you to stop and reflect. Like every single pediatrician I know, without exception, is bigger and better and stronger than they realized. And COVID proved it.
Right.
Right. The number of pediatricians, the idea right now, if we had another epidemic of some kind, let's say we have a monkeypox epidemic, okay? And the word comes down, hey, we have a vaccine. We need you to run vaccine clinics the next 3 weekends. Anyone here going to have a panic attack? Nope.
Nope.
Right? Now, pre-COVID, half the pediatric practices would have said, oh my God, I've never done one of these before. What do I do? And how do I do this? And, the world was filled with it. You guys were on the PMI cast. So like everyone, like, how do I deal with employee retention, or what are these? Everyone would freak out. But now pediatricians are like, okay, America, if you need someone to distribute the vaccines, could you just give them to us because we know what we're doing?
Yeah.
Right? Everyone get behind us and just shut up, because we are. And so pediatricians are like the Bilbo Baggins or the Dorothy from Oz or Luke Skywalker, or it's all of these Joseph Campbell, Myth of a Thousand Faces. Some of you know what I'm talking about right now. The reluctant hero position is one that you were all thrust in. And the biggest change in pediatricians, and this is something, it's personal for everyone, but you are not the doctor you were in 2019. You are not. You're a very different doctor. Now, I could go back to both of you in 2019 and say, you weren't the doctor you were in 2017 either. But boy, the 2017 and 2019 doctors looked a lot more alike than the 2022 doctor and the 2019 doctor. And that's true for all of you. You've grown. You realize what you're capable of. You realize what you're not capable of. I hope that pediatricians are realizing how important they are in their communities and to the entire social fabric of the United States. Because without pediatricians to take care of our kids, none of us go back to work.
Correct.
And so those are the big changes. Those two things I'll say are the big ones.
Great. And let's touch a little bit about because it did change. So are you seeing in your data that the well to sick ratio is normalizing?
So yes. All right. I don't think you know yet what a loaded question that is for me, because all right. So rewind to May, June 2020. We were all freaking out. Everyone was freaking out. All right. I know right now, I don't have George's numbers anymore, but I know right now his volume was down about 60, 70%. Okay. Right. Those first 3 months, March, April, May, June. Sick visits off the table. Well visits dropped, but not as much. However, and I'm saying this without knowing George's numbers, but I bet I can guess pretty well. I'm going to say that. And so I said it publicly many times. I am worried, because all of these kids not coming in for these well visits means that we're not immunizing. And I ran tons of data showing, look at the impact of COVID on measles. Like, I was afraid we're going to have a measles outbreak. I said it. When is our first measles outbreak going to be? Now, it got so far. I mean, I did so much looking into this. Our data made it to the cover of the New York Times. We're in the Wall Street Journal. We're in New York Times. We're on Good Morning America, because we had the data first, because we can do it fast. So then that fall, CDC. So I'm saying this from memory, October, November of 2020, CDC came out and said, look, we have millions and millions of kids who aren't getting their vaccines. However, around that time, I was starting to see different data. pediatricians across the board, now for individual practices, this may not be true, but across the board, pediatricians had done so many well visits. So they did have a dip, but they came back and did so many well visits from like June, July, August, September, October, November. I will say right now, I don't think pediatricians did more well visits in the month of November in history than they did in November 2020 and October 2020. I mean, is that it was like that was the preponderance of your revenue, let alone your visit volume. That at the end of the year of 2020, essentially, more or less every single preventive care measure that we track was actually better in 2020 than it was at the end of 2020 than it was before COVID. All right, now there's more to this. So literally all of those missing sick visits and pediatricians saying, well, we got to do something. So they started recalling people. All right. They were getting kids in. Now, just as an aside, that's very, very, very interesting, because one of the things I worry about when I see something like that is like, okay, is that true for just the kids who aren't on Medicaid? Do the kids on Medicaid perform worse? And it turns out, at least among PCC's customers who are, every now and then someone tries to tell me that PCC clients don't do a lot of Medicaid, and I'm just going to state unequivocally, that's BS. Our clients average 25%, 30%, and that's the national average. We have clients who are 90%. We have about 15% of our clients see none. All right, but we look like everyone else. Mm-hmm. One of the things that we found really interesting, and this is what we attribute it to, I don't know for sure, but it looks like when the fall hit and some kids were going back to school, and this is very true as well in 2021 as well, the super busy fall, that because so many well visits are attached, adolescent well visits in particular, are attached to sports eligibility. Mm-hmm. If you want to play football, Johnny, you got to have your well visit. And with a lot of kids not playing sports, the kids whose well visit rates dropped the most were actually private insurance kids, because the kids on Medicaid who are less likely to be playing in an organized sport in high school did not have that same drop off of demand. And so what we see is the Medicaid kids, it's imperfectly measured. I want to be clear. It's just an interesting thing we noticed. The Medicaid kids were doing well visits at a much higher rate for longer than the private insurance kids. So now that all that said, to go back to it, at the end of 2020, the well visit, the preventive care measures were better than usual. They dipped again in 2021 a little bit, or they stayed then in the fall of 2021, where you got overrun with people. You did do a lot of well visits in 2020, in the fall of 2021, like a lot. But you had all those kids going back to school, all those kids who needed COVID tests, all those kids getting vaccines. I'm like, September, October, November 21 were the busiest months in pediatric history. All right. And at that point, since then to now, the well visit coverage rate is about what it was before COVID. And right now, all the well visit preventive care measures are about what they were before COVID. So where I was originally panicked and freaked out that millions of kids were going to go without immunizations, I really believe that for most kids, well, there's one huge asterisk in a second. For most kids, they did okay. The big asterisk is my clients are all pediatricians who represent primary care, PCPs for children who don't have a primary care physician, and are millions of them. I can't measure them. I have no idea how they did, and I doubt they did well. I'm only talking about the kids who are fortunate enough to have an independent pediatrician. Oh, I'll also say, let's be clear. All right. All of my clients, no matter how they get paid, they eat what they kill. So during COVID, they were motivated to actually provide care. You're employed by the hospital, the well visit volume goes down, you only have 3 kids signed up for today. a lot of hospital-owned practices lost a lot of money during COVID.
Correct.
And in independent practice, that's not true. Yes, we had clients lose money, but at the end of 2020, across the average, PCC client revenue was down only 4% at the end of 2020.
That's good.
Yeah,
That's very good.
I would have predicted 20 to 30%.
That's good.
And do you and Polly still think that the target, to be profitable is about 22 patients visits per day per FTE?
Well, okay. When you frame it that way, I'm keying in on the word profitable. To be profitable, the number is much smaller than that. Even if you treat yourself as the business owner as just a working clinician, because you should. When you own the business, you actually have to wear two hats. I'm the doctor seeing X number of patients per day and getting paid Y for that. And I'm the business owner who may get some profit. I absolutely have clients who do quite well at 16 kids a day. I bet I have some even at even less, though it's definitely harder to do. So when you say profitable, if I look to say, like, did the organization make a profit? That number's fairly low. If you're like, oh, did the owner of this business actually make enough money to want to continue to do this job? Right? Yes, it is in the neighborhood of 18 to 22 a day. The average among our clients is it's a little bit over 18 a day. I mean, I have clients who see 50, but it's 18 a day. And the real secret, this should be no surprise to anyone listening.
Efficiency.
Oh, well, yes, George, I don't argue with that, but I'll tell you the real secret that affects that number, and that is having people work for you. So not everyone is designed to own a business. Okay. Right. And so if you're a solo pediatrician, you might need to see, depending on your overhead, you might need to see 20 to 25 a day to pay all those bills, because you're an army of one and you don't have, it costs you money to do stuff. But if you have two or three, two or three doctors, and you employ 2 or 3 nurse practitioners, or you employ 1 or 2 pediatricians, then, and those pediatricians are effectively giving up part of what they would earn as a business owner to sleep at night. They don't have to worry about rent. They don't have to worry about the vaccine fridge. They don't have to worry about any of these things. They just come in. It's what I call it. It's like, the guys don't know this so much, but if you know what it's like at a hairdresser salon, most of the people who work at a hairdresser are renting the chair. Someone owns the business, someone pays the rent, someone gets all your supplies, but you're giving them 10% of everything that sits down in that seat. All right. And it's the same thing in medicine. All right. It's if you have a margin of 10% on an employed clinician, which is my rule of thumb, the number I like to have, that employed clinician can go start a new business, go get credentialed, go hire some people, go do all that crazy work, or just pay 10% to the house and see some patients, and everyone wins. And you have 1 or 2 or 3 people making you 10% because they don't want to worry about rent. Everyone wins, and the house makes the most money. That model hasn't changed in any industry ever. Right?
Yes.
Yeah.
Yes.
Right.
It's sometimes difficult. The employee physicians
Yes.
don't think that the managing partners are doing anything.
Yeah.
And that's always the rub.
I am a big fan, as when I do consulting and people ask me, like, how do I explain to this employed physician, how this works? I'm a big fan of transparency. I just worked with a practice. The doctor sent me a copy of the letter that he sent to this doctor he's trying to employ. She was asking for hospital money. Whatever. She wanted $225 plus a loan payment, all this stuff. And he's like, I can only pay you $175. Here's why. I'm going to show you I'm not going to show you his books. And he would have, but I'm going to say, look, you see 21 visits a day. I get $150 a visit. If you see this, it's going to bring in $650,000. My overhead right now is 62%. I'm going to have this amount of money left to pay you. I'm taking 10% for myself. You get the rest. We can figure that out. And she was like, okay, I like it, because she got it. She wanted to practice there. And he was like, look, if any of my numbers are wrong, If I'm wrong and I don't make enough money on you, my risk is that I'm going to pay you this money. But if they're wrong and you're going to make more money, we can figure out how to split it. And that's how everyone wins. And to me, the way to ensure that you make good money is you just build your margin, your practice margin into the fee arrangement with the practice, then it doesn't matter. You're like, hey, if this employed doc wants to be twice as busy, they will make twice as much money. I got my piece.
Right.
Nothing wrong with that.
Thank you.
And then there's a question that comes up very often. People are concerned that with all the mental illness that we're seeing in kids, how are you going to survive seeing, say you're seeing 20 patients a day, 10 well childs and 10 anxiety or depressed kids?
You're asking the toughest question. I don't know. I think it's really hard. I have some small ideas. Like everyone here should do the REACH program, which is a weekend long thing that really, I say this based on secondhand knowledge, but everyone I know who's done the REACH program teaches you how to help manage and treat some of these kids. We clearly have a mental health crisis in the United States. I'm the parent of 2 young men, and with them, between those 2 and their friends and everything we hear, it's an epidemic, and I don't have an answer. I do think, however, you have swapped otitis, or you've swapped anxiety for otitis, and it's not a fair. Yeah, it's not a fair trade.
Yeah,
it's not a fair trade for the kid either. I don't have a great answer there. And I will say PCC gets 2 or 3 emails a month from vendors, Herb, doing exactly what you're saying about, we've got this solution. And I always say to them, okay, show me how it works. Tell me how you're going to make money doing it so you survive. And if I think you're right, I will gladly introduce you to thousands of pediatricians, because what you're talking about, everybody needs.
Yeah.
But right now, you're just a .com or whatever, or you got a bunch of venture capital from someone. Until you can show me a little proof pudding, I'm even willing to take a little risk. If you tell me, like the big one I get all the time is, or there are 2 big ones. Number 1, we have a device / software program / whatever that can diagnose autism. Okay, had a bunch of those. And then the other one is we have a way to get your patients the mental health services that they need. And there are 40 flavors of that. Telemedicine, we find someone in your town, we'll embed someone in your office. In a way, I don't care. If any one of those actually started to work, I would be plugging them on here. Did you hear about so-and-so? Oh my God, I don't know of a pediatric practice in the country who would not take any sort of mental health clinician today. They're like a male pediatrician. They're unicorns. It's the truth.
I'm a unicorn.
Yeah.
Yeah. It's true.
Right.
And do you think the market will rebalance such that independent practices will be once again
former glory?
Not former glory, and this is a little political, but the Obama administration's idea of medicine was that, we were all going to work for a huge health system. If you're in Cleveland, everybody's going to work for the Cleveland Clinic, so that there's big data and there's efficiency and everybody's going to do this. And the government has one check to write for that area. My idea is that the more independent, high quality practices there's around, that keeps competition and consumer choice available. Yeah. So that's better for society.
Every single study shows that independent medicine is cheaper and better, without exception. It's over and over and over. I could probably put a Google alert out for all the papers being written that show when physicians become employed, they become less efficient and less effective. Now, I didn't hear you screaming when the Bush administration decided to fund 1 million FQHCs and RHCs, but whatever, okay, because they pushed out all the independent practices as well.
Yes, they did, and yes.
So there is, I mean, okay, the nerd in me sees the point of that amalgamated understanding. All right.
It's not
Because
wrong. It's not
it's
wrong.
not wrong. It's just but it's not that simple, as you know. So do I think the market is going to rebound like that? I've been doing this for more than 30 years. This is probably the third major round of buy-ins and buyouts that I've seen. Okay. You know, right now, the flavor of the decade is Pediatric Associates buying everyone, right? George, have you gotten your offer yet?
No, I don't
Okay.
need.
No, you don't.
I get hustled by every other organization every other week.
You're Long Island. Like you get more than most people.
Yeah.
So that concept has existed. I mean, the first 2 times I used to panic. Okay. And it is possible that this third time is going to be the thing that breaks it. All right. And using Pediatric Associates as an example, they are targeting, unlike their predecessors before them, they are targeting larger practices, and they are generally targeting some of the better run practices. Right. In the good old days, when the hospitals decided to play risk and buy up practices in your town, they always bought the bad ones. I mean, it's almost always true. Like who sells to a hospital? The weak practice. Okay. Right. Pediatric Associates is a little bit smarter, and they're buying some good practices. So maybe that is dangerous, but I've been through this a couple times. These storms hit, and guess what happens? The same thing that made you and George probably sit up at the front of class in biology in high school or whatever it was. It's whatever it is. It's that little bit of alpha. It's that little bit of like ambition. It's that little bit of realizing that you are capable of doing a little bit more than maybe some of the kids you grew up with or whatever it is. That part doesn't go away for most people. And you wake up 2 or 3 years into your employment by this large healthcare system, and you're like, oh, this sucks.
Yeah.
And so PCC has unequivocally made a living over the last 30 years, in large part by people leaving their existing health systems. We have the number of second round clients PCC has must be a multiple of what our peers get. I mean, we get our two oldest running clients from 1987 and 1988. Okay. They left us, joined what was effectively a big Kaiser group at some point. And then they both left, and they both came back. Okay. Because they were like, now that we're back out, we want to run a practice properly. So there's one way to do that, PCC. And we have a lot of practices like that. So Herb, when you asked me about the market, I mean, the first thing I jumped to is, well, how is PCC going to do with this? And PCC's ambitions are not to take over the world. We don't have any investors like that. We don't have venture capital. We don't have PE. We don't owe anyone. We have no debt. So we're not trying to ramp up and get as big as possible to sell, which is what everyone else is doing. Okay.
And then it goes bad. It's just, it always ends in misery.
We are the same people, and we're not changing. All right. There are no offers on the table. We're unemployable and unpurchasable. And so for us, for the volume of business that we need, I'm very comfortable with where we are. Of course, that could change in a heartbeat, but we have there are enough ambitious pediatricians who say, I want to do this in a better way. And I want to have a relationship with my technical and consulting partners so that I can pick up the phone and maybe get an answer to a question. I mean, like, George hasn't been a client of mine in 10 years, 15 years.
No, not that long. Yeah, 2016.
Almost 10 years. All right.
Not
7 years. All right. He hasn't been, but he knows, he can pick up the phone and call me anytime.
I do all the time.
Herb, you've never even been a client.
No.
All right.
No.
And you pick up the phone anytime. But that's the business we're in.
Yeah.
Would you ever say to a patient, to a kid who's on the sidewalk, hey, you're not a patient? Like, it doesn't work that way. That's not. Right. So the reason I'm saying this, okay, literally here at PCC in the room next to me yesterday, we were having a meeting with our sort of strategic team, and we were reviewing the values that PCC has, and it's at first those discussions are always boring, and then you start getting into some really interesting insight from people. And one of the people at our company, George, you may remember Justin. I don't know if you remember Justin, but this is a guy who's very smart, capable, but super nerdy. All right, we all are, but he's like a level above me. He's really his focus historically has been in EDI, electronic claims, data exchange, and so forth. And he was the one who said that the word that he was trying to work into our discussion about values specifically was the word humanity, and how we are in a relationship business. We are not selling widgets. We are not trying to get as big as possible, as fast as possible. We're not trying to cash out. We're actually trying to meet people and make their lives better, because when we make their lives better, they make the lives of children better. And what better job is there than that? There isn't. Yeah. And so I still have faith. Yeah. I still have a lot of faith that there is room in the world for that kind of work.
They say in the House of God, the second one, the sequel, the fat man says, let's put the humanity back into healthcare, because they're totally against the HRs and things like that. The guy's right.
Yeah. And I agree with that 100%. Yeah.
We lost.
I think Chip's always been very generous with his time and with his knowledge, and really, I mean, truly being an evangelist, and a lot of times more effective than pediatricians in leadership for the need of independent pediatric practices, and how that improves community and society as a whole. I'm not so concerned about the pediatric associates, or what used to be called pediatrics, or whatever model you want of super groups. I'm more concerned with the health systems, because not only do they buy up the primary care practices, do a really poor job of running them, lose money on every doctor that they hire, but they also then control the imaging center, and they control the ambulatory surgical center, and the Medicaid patient, they don't care because the government's paying their bill. But the hardworking folks of America end up having to go for an MRI that's $2,000 off of their deductible. While if there was some competition, they could get the same MRI for $400. And that's just not fair, and it's not very nice. So the more independent physicians you have, the more you counterbalance that kind of billing that's unfair to the patient.
I agree with everything in your statement, except for the juxtaposition of hardworking Americans and Medicaid families, because those are not separate things.
Well, you're probably right.
But I also believe, though, that you and I agree fundamentally, the issue there is the third party the two third parties in the room. It's the healthcare system and the insurance companies.
Correct.
I've always said that pediatricians should hope and pray for the collapse of the healthcare system in the United States, because you'll do just fine. All right. Yes. I've said, actually, I've had these discussions with both of you. Right now, on average, a pediatric patient generates probably $30-$35 a month in revenue for a pediatric practice. That's what the average is. It's nothing. $35 a month. $30 a month is $350 a year, which is obviously 3% of their insurance premiums or whatever. It's a teeny tiny number.
Nothing.
And if the entire world, if our next president came in and abolished insurance, which wouldn't be the worst thing in the world, but if came in and said no more private insurance, it would be bad. But let's say they did that, you guys could you have this strange business model where you could live on a cash basis quite handsomely and still be at the very top of the food chain. I think the only other people who could do that are drug dealers. To look at your parents and say, and keep in mind that $35 a month includes vaccines. Okay. So to look at your parents and say, everyone here, if you want to ever see me, if you did it for everyone, you wouldn't have to wouldn't have to charge them $35 a month. You could probably charge them 30 or 25 because there are no more claims, no more billers, no more, like, you're just seeing people as long as they need to be seen.
Yep. And that's why the DPC model, I think, has some traction.
That's
you
for
know,
real.
and again, I don't want to be mean. I'm talking about the working person in the sense of the person that's paying $18,000 or $25,000 to insure their family. Both mom and dad are working full time, and they have $5,000 deductible.
Yep.
And every time they go for a service, they get a $200, $300, $500 bill that they have no control over.
Yep.
As opposed to the Medicaid patient may be working really hard, but they go in.
They have coverage at the
The cost is oblivious to them. You know, it gets paid for. They don't know how, but it does, and they don't have to struggle to pay that $500 off their credit card.
Yep. And I think one of the differences between how you and I see that, though, is I think of that $18,000 to $20,000 that family is paying for their premiums. That's just a tax. That's a tax, and that's a tax that goes directly to Cigna and Aetna and so forth. So when we talk about single payer, and believe me, I have massive concerns about single payer, but frankly, I would rather that tax be eliminated, go right to the families, to their pockets. And I'd rather have us pay all a little bit more in income tax and have coverage. Now, it's not that simple. Yeah. But what I don't want, the greater evil to me, is that $18,000 is no different from a tax, and it is going right to Cigna and United and Aetna, and that's.
Well, I think this is a podcast in itself that we have to do in the future. You know, we've already chewed up a lot of Chip's time on this one. It has to be the longest podcast we've ever done.
Yes,
but Chip is great.
Yes. Well,
I talk a lot, guys. Sorry.
No, we love it. This is why we, this is why we like to talk to you.
Do you have Chip? Do you have any recommendations for anybody else that we should get on the podcast?
Yes, I'm going to give you a recommendation for.
Call them out. Call them out.
There are 2 or 3 pediatricians right now running for Congress. And you also have Kim Schreier, who's already in Congress.
Okay.
Kim Schreier is the one who hoisted up the bipartisan Medicaid bill, the one that is going to pay. I mean, oh my God, if it gets passed and it's got bipartisan support, it changes everything. It means all Medicaid's paid at parity for Medicare. It means they have to start paying IMS admins properly. They fix VFC. There's all this stuff that is just long overdue.
Well,
I would get some of those people on.
Yeah, introduce us to them.
And you said you already did a bunch of DPC people.
Yeah.
What I would tell you is, because rather than have me hum and haw here for a while, if you guys send me an email saying we're looking for people with these themes or these concepts, I will bounce you names and or introduce you.
Cool. Thanks, Chip.
That's great.
Yeah.
Sounds great.
Right.
Well, you keep doing the great work you're doing. I always appreciate your insights and chatting with you.
Yeah.
Well, thank you guys. I appreciate it. And keep up the good work.
Say hello to everybody at PCC for me.
I shall. And I think, are you both going to be in Anaheim in 3 weeks?
No, I'm not.
No, I got to be there by myself. All right.
Yes.
Well, I will be.
I'll be at PMI though.
Okay. I will be at PMI.
Yeah.
Yeah. But we will see you guys soon. Stay healthy.
All right. You too.
Keep up the good work.
Thank you.
Bye-bye.
All right. Bye.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.